Absolutely. Present. I'm going to pull up our presenter's presentation here. Make it large. There we go. We're going to go ahead and get started. So we want to thank Bircham Hills, our presenting sponsor, for their support for the Understanding Chronic Conditions series, as well as our platinum sponsor, which is Diamonddale Nursing and Rehabilitation Center. So we thank our generous sponsors for their support of this series. Today's presenter is Carol Tucker. Carol is a nurse and a nurse practitioner who's worked in diabetes services for a number of years. She received her master's of Science in Nursing and Adult Chronic Health from Madonna University near Detroit. She spent 29 years with the University of Michigan Health System and 7 years with the Grunberger Diabetes Institute in Bloomfield Hills. She served as a nurse educator for nursing students, nurse practitioners, physician's assistants, medical and endocrine residents, and fellows in the care of the diabetic population. She is an active speaker on a variety of diabetes topics for community events and professional conference. So I'm really excited to be able to welcome Carol to kind of conclude the series on a topic that is so important to many of us here in the Mid-Michigan area. So I'm going to go ahead and turn it over to her. And you'll just be able to click through on your slides. This is the...
Okay, and then mic is on.
Yeah.
Oh, thanks. All right. Everybody hear me, I take it?
Yeah, I hear you.
Yeah, I'm old enough now. I need a little tutorial as I do this. So yeah, I'm good. So I guess I don't need my mask. I probably don't need my white coat, but that's okay. So there's a lot of information to talk about when it comes to diabetes. And my goal basically is to get all of the information or all the questions you have answered. So I'll get started. It might actually trigger some questions that you might have. So we'll kind of get started. Let me see, I gotta do page over, right?
Yep.
Just a page over?
Yeah.
Okay. So I wrote these objectives about, a week or so ago. So I probably dropped some more information in there, but most of the questions I get from patients when I see them, either as a new patient or the patients I've been seeing for, several years. It's always nice to know where we are. And I want to do a little definition of prediabetes and diabetes because some people get a little bit confused, I think, sometime. And then we're going to talk about actions and myths and so on. But yeah.
Marcia, can you mute yourself?
I can't even hear you now.
You can't hear us?
No. What happened? Do you know?
Audio's working here.
I can hear you.
There's faces.
Yeah, I'm not sure.
Yeah, Katie, I can't hear you at all. But I did hear the fella who just spoke. Fran, can you talk?
I can hear Marcia. I can hear Katie.
Fran.
Okay.
I just can't hear you.
Okay.
Is
Marcia,
my
why don't
voice
you try
gone?
logging off and logging back in or using the call-in number? It might be your internet slow enough that you can't get the audio.
Huh. Let's see.
I don't have a way to help you, Marcia. If you can't hear me.
I can hear you. I
Oh,
can't hear.
you can?
I can't hear Katie. But Katie's not talking right now either.
That was Katie just talking.
Yeah, it was. Okay. We're going to have to mute everyone so we can continue on. I'm so sorry. Okay. I'm going to have to close her. She's going to figure it out.
Okay. All right. So we'll keep going here. No, wait a minute. Not. It's to do her. Okay. All right. So some of these numbers you may have heard before. It is now a worldwide epidemic. It was mostly the developed countries that had diabetes. But what's interesting is people move to the United States, they become obese. So now we've got, as more and more of the world adopts the developing countries' lifestyle, they're gaining weight. So there is actually, for America, about almost 35% of the people, American adults, have pre-diabetes, and about 25 have diabetes. I gotta tell you that most people, like 85% of the people, don't know they have pre-diabetes. And that's probably where we're trying to focus the most clinically. And then some more numbers on there. There's no, these numbers won't be on a quiz, but there's just to show you that there's millions of adults and children who are diagnosed with diabetes. And again, remember, 85% of the people don't know that they have diabetes, so there would be even more than that. And it's a very expensive disease that we're managing. So who's at risk? So for those of you who do not have diabetes, or who have pre-diabetes, or who have a family history, or don't know, these are the risk factors that are pretty well established that everyone learns early in their clinical career. So if you're 45 years old or older, you're overweight, obese, unhealthy diet, you're inactive, you have a parent or a sibling with diabetes. Now, I've got to tell you that probably a generation ago, you didn't talk about it if you had sugar, as my grandmother would say, but people didn't talk about it. So they might, if you ask any family member, or when I ask patients, do you have a family history of diabetes? Sometimes I'll hear, oh no, there's no diabetes in my family. So type 2 has a huge genetic component. So chances are there's someone back there, but you may not know because there was a time where you just didn't talk about it. So you also have high blood pressure, high cholesterol, low good cholesterol, you're at risk. And a woman who's had at least gestational diabetes with at least one baby probably has about a 99% chance of developing diabetes, and actually should be monitored yearly because the risk is so high. The other thing is ethnicity. If you're Hispanic, Asian, Native Indian, African American, and the Pacific Islander, such as like Hawaii and some of the islands down there, you have a huge risk of diabetes. What's interesting, there is a Native Indian or Native American tribe in the West that 100% of the people who live on that reservation have type 2 diabetes. So it's well known because they're used a lot in research when we're trying to look at culture and some other things going on. So, all right. I kind of want to define this, and you'll hear terms tossed around as pre-diabetes, glucose intolerance. Don't worry about the nitty-gritty of it. Just know that if you have a fasting blood sugar that's between 100 and 125, a clinician or your doctor or whoever's your provider is going to look at that and say, it's starting to get into glucose intolerance. Then if you're between 140 and 199, just a random or a 2 hour after a 2 hour glucose tolerance, again, that's another pre-diabetes, and then a random blood sugar of 200. All of these numbers will be increased. So when do you have diabetes? You have diabetes when your fasting blood sugar is higher than 126. You have it if your 2 hour glucose tolerance test is higher than the 199 or 200. And if you have a random sugar greater than 200, that's diabetes. And if you have an A1C that's 6.5 or higher. I will tell you that a diagnosis of diabetes should not be made on one number, one time. That should be done like repeated, not on the next day, but give a day or two in between and repeat whatever test they're using, whether it's an A1C or blood work. All right, prediabetes. That is not an automatic lead to diabetes. Often it does, though. But the thing I always like to tell people, if you're, it's a journey. The pre-diabetes leading to diabetes is always a journey. It's a linear kind of journey. But even though you may have inherited the genes for diabetes, there's a huge amount of behaviors and activities that you can involve to slow that process down. And sometimes it doesn't even develop into diabetes. For example, there's diabetes all over my family. I hear that a lot. I've got uncles and cousins and both parents. And I've had prediabetes for over 10 years. So if you kind of watch things and follow some recommendations, you really do have some control over the speed or the severity of your prediabetes. If you think you're at risk, if you think you have symptoms, then just ask your provider. Say, can you test me? Can you check my blood sugar, or just do labs and check and see if I have diabetes? All right. I want to make a distinction between type 1 and type 2, just because I think there's some misinformation out there. So type 1 used to be called, because of the age of you guys and me too, there was a time where type 1 was referred to as juvenile diabetes or insulin-dependent diabetes. We no longer say that anymore. Type 1 diabetes is autoimmune, meaning their body fights basically the cells that make insulin. Most people who are diagnosed with type 1, it's usually faster than the type 2, and it might follow like an acute illness or surgery. And I have diagnosed type 1, new diagnosis in people as old as 80, so it's no longer just for children. So it really is what causes the diabetes. So this one is basically autoimmune. They're going to require insulin either at diagnosis or maybe soon after. Sometimes I've been able to watch them carefully, but it's usually a short period of time. And these are the people, again, that will require insulin. Now, type 2 is 90% of the people who have diabetes. Type 1 is about 10%. I also think type 1 is underdiagnosed, but that's my lecture for some of the residents. So type 2 diabetes, we used to think that the lead into type 2 was about 5 to 6 years. And now we are looking at probably between 10 and 20 years before someone is diagnosed with diabetes, they have started having cellular changes, even though all their numbers might have come out fine with their labs. So this is a slow onset. It usually begins with the body struggling to bring the blood sugar down after a meal. Again, it gets it back down. And if you drew all the lab work, you would have normal labs, but the body struggles. It, again, it's genetic and lifestyle. Type 2 may require insulin at diagnosis, because sometimes people get diagnosed with surgery, or they had a major trauma or a major emotional trauma. And when our body's under any kind of physiologic stress, we produce a lot of cortisol, and cortisol is a steroid, and steroids actually increase your blood sugar. So if your body's struggling to deal with sugar, then that might actually precipitate a diagnosis. So sometimes we have to give people insulin just to get their blood sugar levels down, and then we can move to other agents. And one of the myths, I think I put it near the end of the presentation, but one of the myths I hear a lot is once I start on insulin, I can never come off, or insulin's the bad, is the bad diabetes. It's not bad or good. It just means your body is unable to make enough insulin to meet the demands of the body. So it's not good or bad, and the person isn't good or bad. And we have started people on insulin and pulled them off. And this is an example with diagnosis when their blood sugar is so high. We just need to get it down. But I keep going back to the severity, and the progression is influenced by behaviors, and we'll kind of get over that. But it's not a death sentence. There's a lot of things that can be done to slow the progression down. I don't have this in my notes, but you will hear and may have heard a lot of things on TV. I'm not allowed to listen to commercials because I go ballistic on some of them, but you will read things, you will see commercials, people who have bariatric surgery and they've been told that they have a cure for diabetes. I don't use the word cure because we don't have anything I can give you right now to zap the cells and make insulin to make them work. It's in research. We're looking at stem cells. We're looking at some medicines, but I don't have anything to make those cells work better. So I don't look at diabetes as being cured because the underlying deficit is still there. However, we have things that can, the bariatric surgery will put somebody in remission. So they may not need medicines, they may not need very much, but you go into a remission. So sometimes people say, oh, if you take this, we'll cure your diabetes. I just, I guess I just look at it as they're trying to sell snake oil because we can't cure diabetes right now. Not yet. We're working on it. So, all right. Next. This is a busy slide. I think I was just in my teacher mode when I put this slide in here, so you don't have to worry about it. But if nothing else, take away the fact that there are multiple deficits or defects that go into type 2 diabetes. There's, maybe the way to look at this is supply and demand. This is how I like to present when I'm seeing a patient and I'm changing their medicines around. If you look at managing your diabetes, all your actions, your medicines, everything you're doing is going to go on one side of a scale or the other. You're either going to decrease the demand for your body to produce insulin, or you're going to increase the supply. So whenever you're given a medicine or told a behavior to do, if you think about, well, what side of the scale is this going to go on? Am I going to decrease the demand, or am I going to increase the supply? And most likely, we're going to do a little bit of both. We're going to do several things. So you can look at this. Diabetes involves the liver. It involves the muscles, the pancreas, the brain. There are 14 systems. And we know 8 of 11 have deficit, but now we're saying 11 of 14, and I might live long enough to see them say officially it's 14 out of 14. Because if you think about, this is about sugar. And this is about your body's ability to use sugar for energy. So if your body's an engine, you need fuel. And the fuel is the carbohydrates. So when you eat the carbohydrates, the body's got to convert it into fuel and move it into the cell. And that's where insulin comes in. So this is, people say diabetes, I'm going to do everything to bring my sugar down. Well, you are, but I like for people to kind of step beyond that and think, well, why is my blood sugar going down? And it's going down because you're moving the sugar into the cell to be used for fuel. So this is a supply and demand kind of approach in the management. And it's all about creating efficiency in the body and the body's ability to use carbohydrates as fuel. It's so quiet. This is kind of weird just talking to this screen. I can't get any feedback. Okay, so lifestyle changes. There's something up here I can't see behind. That's okay. Whether you have prediabetes, type 2, or you just want to get healthy. I mean, some of this is just healthy stuff. And that is, one, you want a healthy meal plan. We'll talk about that a little bit later. But let's say you have prediabetes or you suspect, what are you going to do with your food? Well, first of all, you're going to eat healthy. And please do not do the, I can't have anything white. I can't have any juice. I can't have any fruit. I can't. Because if you come to our clinic, we do not take any food away. Food is food. There's no judgment. Now, I always tell people I might reserve the right to say less or fix it different or less often, but we're not going to take food away. So if you're concerned about your meal plan, just start watching how many carbohydrates. Again, supply and demand. If you have a steak with potato and bread and a big dessert, your dessert, of course, your demand's going to be more than just if you had, a steak and a salad and one roll and maybe half your dessert. So you're not giving it up, but you're just watching the load that you're putting on your body. So physical activity, everybody wants to know, well, how active and how much do I need to do? Well, you need to do 150 minutes a week. You can do it some every day, 30 minutes every day, most days of the week, or you can do 150. Probably better if you just do some every day, not try to do your 150 in one day a week, but you just want to stay active. And this is just moderate activity. Walk. Park the car further away from the door. Be careful that you can do that, but again, we'll talk about that later. If you have type 2 diabetes, you I'm hoping you will be given a meter to check your blood sugar. Now, do you have to poke your finger a lot? No, it depends on where you are on your blood sugars and what kind of management you need it to in the beginning, but you'll be monitoring your blood sugars. And again, there's some messages, and this comes from doing this 25 years of just diabetes. And diabetes management is a mind game. And if you look at, I'm a good person or a bad person, or I ate good or I ate bad, or I'm a bad diabetic, I hear that a lot. That is a defeatist. So just know that when you monitor your blood sugars, it's like checking the gas gauge. It's like when you don't feel good, you're checking your temperature. You're checking a number so that you know where you are, and then you may be given tools on how to address it. So if you start viewing it like that, it puts you more in the driver's seat. And that's what I don't want people to feel defeated with this. So you also take your medications, take care of your feet, and a lot of this, if you have diabetes, you've probably already been told that. All right, I'm going to move on because there's a couple things I really want. Meal planning. All right. So everybody says we want you to go on a diet. We don't like to use the word diet. It's a meal plan. There is no, this is going to be more specific toward the more mature person, since that's what we all are. At least everybody in this room, except for Katie, she's young. But anyway, there is no concrete meal plan for the mature person with diabetes. These are kind of guidelines. Carbohydrates and monosaturated fats should be about 60 to 70% of your diet. Now, a lot of people are asking me, can I go on a keto? Can I go on a low carb diet? We don't like keto, and I'm not going to get into the physiology of that because that could put you in ketoacidosis. I have changed over the years, saying that you can have less carbs, total carbs in a day, but we've advised that you don't go less than 100. And that's because carbohydrates, 100% of the carbohydrates affect your blood sugar. And that's because that's your body's fuel of choice. So if you cut way back on your carbs, you're cutting way back on your fuel. Yes, it helps burn fat and lose weight, but there's a point where you need some carbohydrates. So you don't want to get down to, very little. I've heard some pretty low carbohydrate, and that's not very good. But anyway, so proteins are about 15, 20% of your meal plan. People will sometimes pull way back on protein. Protein is the only thing our body can use to build new tissue. So if you want to build muscle, if you want to heal wounds, if you want to do anything where you need more tissue, you want to watch how much protein. You want to make sure you're getting enough protein. Polyunsaturated fats, these are fats that are basically, solid or liquid at room temperature. You want to make that less than 10%. It's hard to do with our diets, especially if you get processed food. Though I'm hearing a lot of people aren't eating in restaurants nearly as much the last 5 months as what we used to, but that's where you're probably going to get kind of stuck. Polyunsaturated liquid and saturated fats, as the solids, but both of those you want to be about 10% of your diet. Fiber. Most Americans do not get enough fiber. They probably get less than 10 grams. It's ideal is about 20, maybe 21, maybe 30. You don't want to go from 0 to 35 grams a day. Your family and your dog will leave you alone if you do, so you want to go slow because you'll be uncomfortable. So that's the meal planning. That's just a loose way to look at your the food that you're eating. So if you want to say, hey, how can I make this better? I would start with that. And you can start looking at, maybe keep a food diary. Don't try to change everything. Just keep a diary and say, well, what am I doing right? You might be doing some things right. You just got to tweak some other things. Now, there are challenges, of course, as we get older. And these might be, and I call them challenges because these are very real things that happen as we get older. So I have patients all the way from the age of, 14 to, I think my oldest patient is 95. So there's a wide range of things that you need to consider. But as people age, or sometimes it's a disease and they're younger, but it's a disease, they'll lose their sense of smell or taste. Things don't taste well. If I can't smell them, then the taste isn't good. You have a decreased appetite. Maybe you have dentures. Maybe you have, I have a couple patients that only have one tooth, or they have periodontal disease. And a lot of medicines that we take dry out your mouth, or your salivary glands aren't working as well. You live alone and you don't want to cook a big meal. You don't have the ability, you don't have the vision, you don't have the dexterity. So these are things that if it's you, there are resources. In our clinic, we have dietitians who are very good about creating meal plans that help with this. As clinicians, we're very aware of this. Most of us are pretty flexible on trying to come up with something that is doable. And you always have the risk of dehydration. When sugars go up, your body needs more fluid to not only move the sugar around, but also to eliminate the sugar through the kidneys. So you really want to stay hydrated. All right. Physical activity. So that's probably what you were told. So everybody said, hi, you have diabetes. Now I want you to watch what you eat and don't eat anything white. And I want you to exercise. There's a good chance that's what you were told. So we talked about meal planning. Now your physical activity. So I talked about 150 minutes a week or 30 minutes a day. Here's the good news. Take note. You could do 3 10-minute walks and it's just as effective as 30 minutes. And if you're like some people, they couldn't walk more than 10 minutes anyway, and that's fine, because if you do that 3 times a day, then you've got your 30 minutes a day. So this is a doable thing. And this is where I say you can park the car a little further away from the door if you can. Certainly be safe first. And the bottom statement, I want to stress this probably, I guess that was a pun, I didn't mean for that to be, but probably have already done this. Anyone who's 35 years of age and older who want to start a fairly moderate or rigorous exercise program really does need a stress test. This isn't just to say, oh, hi, your heart is fine. There are a lot of circumstances where we probably wouldn't want you to do exercise either altogether or we need to modify it. So this is pretty key to say, are you ready to go? Can you do that exercise and do it safely? So these are some considerations. If you're going to do your exercise 30 minutes a day or 3 10-minute sessions, do some resistance training or work 2 days a week. And no heavy weights, please, especially if you have eye disease. As we get older, our joints aren't as limber, our tendons are a little more, tenuous. They get injured easier. So no heavy weights, make it a lightweight. You can do light weights if you're into maintenance. And it depends on, of course, finances. But I'm glad that we see a lot of physical trainers out there. We have physical therapists. And now with cardiac rehab, we're starting to see where cardiac rehab is opening up, not just for the person who's had a heart attack, but actually for strength training so that people can be monitored where they build up. So I think you're going to see hopefully more and more resources for you. What's nice about walking, it's accessible. I guess the main thing would be shoes. It helps with balance and endurance and mood. But if you think about it, those are all things we need to stay independent. Balance and endurance helps with stairs. It helps with being able to take care of ourselves. And that's usually what people really want. If you have arthritis or neuropathy, or you have an altered gait, again, talk to your provider. There are things that are available, or people who are available to do some assessment and to give you some good ideas. Stationary bike and water exercises are good. Stationary bike, that mostly holds my clothes. I don't do well with stationary bike, but I can tell you water exercises was one of my most humbling experiences. I was very young and I went to a water aerobics class with, at the time, they were older women and they had this sponge and they were going in the water. I'm like, well, that's no brainer. I can do that. Well, I got to tell you, I have never worked so hard in my life and actually was embarrassed because the women, I think, were chuckling because they knew what I was thinking. I could not do what they did. So this is a very effective exercise, and it's not hard on joints. It might be hard on your, pride if you do what I did, but it's not hard on your joints. The other thing is you might do chair exercises. People forget that. And there is an ex-Detroit Lion football player who recognized the need for exercises, and he started doing chair exercises. And again, you think I'd learn my lessons. I went for one session to do chair exercises. I thought, I'm sitting in a chair waving my arms around, so no big deal. Well, he actually, the room was full of people, and these were people who have been doing those chair exercises for 2 years. And I go in there just to observe, and he goes, well, go ahead and do it. And I was very humbled by the fact that you can make chair exercises extremely effective. So, all right. These are just some things to, like, tidbits. If you have proliferative retinopathy, if you don't know if you have proliferative or non-proliferative, that's fine. Go to the eye doctor once a year and clear with them saying that you want to start doing some exercises. And that's because you don't want to increase your risk of a bleed. But the ophthalmologist can give you, guidance on that one. If you have neuropathy, this is, pain, numbness, tingling. Most often it's hands and feet often more than hands. When you have neuropathy, it kind of alters, sometimes you can't feel the bottom of your foot, or there's pain and numbness. So you have the risk of soft tissue injury. And again, that's where the bike and the water exercises can help and be very effective. If you have cardiovascular heart disease, it's absolutely imperative that you talk to your cardiologist because of some, can your heart take the exercise, without getting into trouble. This is kind of a caveat. I almost didn't put this in here. If for some reason you're unable to get symptoms of a low blood sugar, I would definitely talk to whoever takes care of your diabetes and talk to them. You want to do exercise, and that is the same system that gives you symptoms of a low blood sugar is the same system that works on heart effect and so on. So if you're struggling with that kind of nerve involvement, you want to really talk to a cardiologist or your whoever's providing your diabetes care to make sure that it's okay, just so you don't get into trouble. Okay, well, this is a confession. I almost didn't put this in here because I do not want to be a downer, but if you should have anything listed, and I don't have to read this to you, guys can all read English or just read. These are things that if you have them, please do not just assume that you'll probably be okay because you just saw a cardiologist and you want to start your exercise. Because these are conditions that you really do need guidance, and you may be told not to exercise or very little. And there's several here. And again, I there's another list here. I don't do this to say that to be a downer, but it's actually for your physiologic safety. And this is where you want your provider to help out. And there's multiple reasons. Some of this is straightforward. You're going to look at it and say, well, yeah, that makes sense. Why not to do it? But so I just put this thing in here, this slide, because I happen to think I've given you a lot of information. So you go into the doctor, you say, I think I might have diabetes because I'm thirsty. I'm going to the bathroom all the time. I'm getting up at night to go to the bathroom, and my wounds, my scratches aren't healing as well. And I'm tired all the time and my vision is blurry. Those are the most common things I hear. So you go in and you get a diagnosis and they say, guess what? You have diabetes. What do you do with all this information I gave you? So here's your top 10 things. Number 1, take a deep breath. This management is a process. You're not going to learn it all in one day. You're going to have ups and downs. Just take a deep breath. There are people around to help you. So then you're going to get ready to go. But take that deep breath and assemble your team. What's your team? Your team is your clinician. It could be an MD, DO, it could be an NP like me. They're going to be your person who's going to guide your medicines and get you into the right people that you need. You'll probably have a dietitian. You'll have an educator. It might be a nurse, might be a dietitian. You'll have an ophthalmologist, and you may be sent to a podiatrist, and whoever they send you to. But the core team is going to be your educator, your clinician, and your ophthalmologist. So they'll start assembling your team when you get diagnosed. Next thing you do, set reasonable and measurable goals. You're not going to lose the 40 pounds. People come in, well, if I lose 50 pounds between now and Christmas, everything will be okay. And I'm like, well, first of all, I don't think you're going to do it. You're setting yourself up, and that's just not realistic. So be reasonable. This is a journey, and you're not going to get everything done in one day. This is going to be ongoing, so make them reasonable. Plan your diet. I know there's the word diet. I don't know why I put it in there, but anyway, plan your diet. And this is saying, if you're like me and you work 12-hour days, if I'm not planning for what to grab something to eat, I'm going to get something that's probably not the best. So, if you plan ahead, this is like taking your lunch to work. And there's a message up here that I don't know what it is. This is your commercial break on this talk.
Oh, we don't want to approve that.
Can you say decline? Okay. Okay, commercial's over. Next, exercise. And I gave you some tips for that. Start real low and easy, park 2 places away from the door and walk 5 minutes a day, and then just keep building up. You may or may not be given a meter to check your blood sugar. I sure hope you're given a meter. Sometimes people aren't giving one. If you'll notice, I said check your blood sugar. You do not test your blood sugar. You check your blood sugar. I pound this into everybody's head. And the reason is, if you tell me to test something, I'm going to think it's good or bad, or I passed or failed. I got an A or I got an F. So you're not testing your blood sugar, you're checking it. You're checking it to see where you are so that you can provide feedback. And even though that's a little thing, it's a big mind thing. So kind of start changing that tape a little bit. You're going to follow your medications. Then you're going to involve people with family and friends who are supportive for you, because that's just support system. And then start looking at resources. You should get some when you go to the office, when you get diagnosed. There are so many websites. If you want to know, diabetes.org is the American Diabetic Association. There are magazines out there, and I've got to tell you, my most favorite magazine is called Diabetes Management. Excuse me. They're very, they cover very timely topics. They don't oversimplify it, but they also make it understandable. It's one of my favorite magazines. I used to get them a lot for patients. So that's some resources out there, and you can just ask, and there's diabetes education. But by and large, your strength. You lived a long time. You've learned a lot of things. You're a smart person. You have a lot of strengths, so that's going to come into play as you do this. So these 10 things, you take a deep breath, you get your team together, you start planning what you're going to have around to eat, you start moving your body, you take your medication, and you get people on board, and you say, I can do this, and you'll be ready to go. So I want to look at the time. There are myths, and I think you've got a copy of the myths. Uh-oh. Why did it not go forward? Did I not do the rest of my slides?
Oh, no, you're good. There you go.
Clearly, this is not my forte. Now, if you want to give me your blood sugars, I can do those in a flash. But some of the key myths are diabetes is easy. No, it's not. It's difficult. Doesn't mean it's not doable, but it's not just to be blown off. It's a serious condition. It's not your fault. It's not because you ate candy as a child. It's not because you ate all your pillowcase full of candy when you were growing up. Remember, it's genetic, and it's part behavior, and it's part genetic. It's not contagious. It doesn't, like I say, it doesn't come from eating too much sugar. And then people are told, and this is unfortunate, if you have diabetes, you've probably experienced this. They'll go to a family dinner, they'll go to a work event, and they're told when they pick up a piece of fruit or even a piece of dessert, they plan for it. Then they ate ready for it. And they said, well, you can't have that. You have diabetes. And so you have these diabetes police all around you. And that's unfortunate. I would advise that you come up with a nice little statement such as, thank you for your concern. I have this in my plan and I'm being followed by people who know what they're doing, or whatever you want to say, but you will have diabetes police all around you. So that's unfortunate. They'll tell you can't eat sugar. It says diabetes always leads to problems. I have had people who have had diabetes for over 50 years and they have no complications. So I'm not belittling the point of complications, but you still have a lot of influence on the severity of this. And the only other things, I think you can read these because I want to give plenty of time for questions. I want to make sure you guys get your information. You get more colds and flus. That's not right. You get the same amount. Person with diabetes gets the same amount as anyone else, unless their blood sugars are really high. That's one thing. You know what? I didn't plan on this, but let me tell you this. So you can tell I'm real strict with my notes. So high blood sugars actually affect the white blood cell function. And the white blood cells is what your body uses to fight infection. So given the current situation with COVID-19, there's been a lot of research, as you are well aware. We're trying to learn so much about COVID. And they wondered why some people with diabetes fared better than others. And the bottom line, it was no surprise, it said those who had lower blood sugars did better. And that makes sense because if you have high blood sugars, you don't heal as well, but that comes from actually interfering with the white blood cell and your body's ability to fight infection. So if nothing else, now's the time to really get your flu shot if you don't get them already, and two, get your blood sugar down. You'll just be helping yourself out. So that's not on the slide. That's just as an aside. Supplements can't cure diabetes. We talked about that. Gastric surgery doesn't cure. We talked about that. You go into remission. We talked about once you take insulin, you can stop. It depends on why you need it. Insulin does not cause blindness. Thank you very much. And I hear that in a lot of things with insulin a lot. If you are on insulin, you have a lot of questions, please ask who's ever given it to you, and they can kind of clarify that for you. This is the last slide, and if you remember nothing else, remember my 10 steps for when you get diagnosed and this one. 1, when you get diagnosed, life doesn't end. You don't have to do it alone. And here's something I tell my patients, and they usually say thank you. It's a unique journey, and it starts fresh every day. You have a bad day, you ate too much, so was a day you ate too much. Tomorrow is a new day. So, are there any questions? Yeah. Okay.
I'm thinking, so I'm going to come back there because
Sure. That's fine. I can grab
in the chat.
Yeah.
Here so they can see it, or so you can see it. There we go. So if you have questions, go ahead and put those right in the chat. I'm going to stop sharing our screen so you can see a Carol full screen and not the little tiny picture of Carol.
No, gee,
She
I
can
know
see
that's
you
good.
all.
I know there are people out there. Actually, there are people.
Oh, I guess it doesn't do that.
You may have to read them to me.
Yeah. Okay. Well, there's no questions yet. There are no questions.
Now, I know I didn't do that.
Or you could. Okay, go ahead.
I know children that eat candy every day. This seems so bad to me. Is that going to give them sugar?
No, if they're kids, if they have a genetic component, they might be at higher risk for developing diabetes. If they have type 1, that's autoimmune. That's a little different. The other thing is whether a child or an adult, when people start getting really hungry and they tell me they just can't get enough or they're really craving sweets, that usually means they have a high blood sugar. And so what's going on is the body says, I don't have any fuel, so I'm going to give the brain a signal to eat. Well, the fuel's right there in the blood, so it's not getting moved. So I guess the bigger question is, why do they feel the need to eat so much sugar? Are something going on, or are they just in a bad habit? And sugar is addictive. You actually have to kind of withdraw from that.
Okay.
Did that help answer that question?
Yes, I can't understand parents that give kids candy all the time.
Well, I sometimes think kids can sneak it too, and then they kind of like it and they keep
The
going
parents
after.
buy it, so kids don't really have that big of a budget to buy candy daily.
Well, that's true. But yeah, so I guess I would look at, besides the parents giving it to them, does the kid, are they just eating out of habit, or are they really hungry for sugar? And then that's where I would talk to the pediatrician if they're really hungry for sugar. But if they're hungry for sugar, they have high blood sugars, they're going to be eating a lot and they're going to be losing weight. So there's a mismatch there. So I would have them talk to their doctor if that's going on. If they're just eating because it's a habit, well, good luck. I guess good luck.
The whole family are constant candy eaters.
Oh, yeah, that's a hard one.
Okay, we got a question from Shirley in the chat. If glucose is under 100, is A1C necessary? I have been pre-diabetic and mom, grandmom, and brother have diabetes and numbers have been higher in the past. I am 70, but glucose last month was 92 with new doctor.
Yay! If your blood sugar's okay, so the answer to the question is the A1C important, and for me, yes, I use both numbers. I know I'm talking, so you guys stay up. So, yeah, you need the A1C because it's actually a 3-month average of your blood sugar, and your blood sugar is changing every nanosecond. So your morning blood sugar should be your lowest, and it changes through the day, which it makes sense. It goes up when you eat, and then it should be coming back down. So the A1C kind of gives you all of those numbers, the average, all that's possible, and then those spot checks are low. That's just saying that your body's able to get it back down. It sounds like you're doing a really good job, and it's a good example of you staying in prediabetes. You probably have made some changes that have kept you at a good spot. But I would at least do the A1C periodically just to make sure you're not missing something.
What does the A1 and C actually stand for, and what does it mean?
Okay, so I love questions that I can answer. So the hemoglobin is the cell that's a red blood cell, and it carries oxygen around to the body. And as it floats around the bloodstream, sugar will stick to it. So your body basically glycosylates the sugar, and that's where the glycosylated hemoglobin A1C comes in. So the A1C, a big fancy, it's the location on the red blood cell that they check the sugar. So it's like segment A, so it's a chemical molecular thing where they find the sugar. That's what the A1C stands for. It's the location on the red blood cell. Just for you to know, it's a 3-month average of your blood sugar, but your red blood cells live an average of about 6 weeks or so. So half of that A1C has come from the past month to 6 weeks. 25% was from the last 2 months, and the other 25% from 3 months. So though we do A1Cs every 3 months, if I'm doing some aggressive changing for a person, you might start to see a change at 6 weeks. Usually insurance won't pay for it. There's another way to check it. But the A1C stands for the location on the red blood cell where they check the sugar. And when I say that when the sugar sticks, it's a permanent stick. What a lot of people, even clinicians, don't know, it takes up to 4 hours before, that sugar can float around that red blood cell for 4 hours before it sticks permanently. And if you think about it, that's about what you're doing between, the end of one meal and the beginning of next. So if you have that piece of pie, you don't have to rush and worry about it. You should have a couple hours before that, 3 hours before that sticks. My old doctor always did both until I can't see.
Can you define the monitor your blood sugar? How do you define that?
I'm sorry, I missed the first part of that. About the blood monitor?
How do you define, or what do you mean when you say monitor your blood sugar? What should we do to do that?
Well, if you're newly diagnosed and it depends on some medicines, you're going to get the blood sugar or blood glucose meter. It's where you poke your finger and you put a strip in there. So I always have people check it like maybe once a day and just mix it up. Some days you're going to do in the morning, some days in the middle of the day, it just depends because it changes through the day. So I just say mix it up. Some doctors, it depends on what you're on, may say I need it 2 times a day or I might need it at this time. But if you're just kind of keeping an eye on it, I would just do it random through the day just to see how you're doing through the day. Your morning blood sugar should be your lowest. And we know it's going to go up when you eat. And by 2.5 hours, 3 hours after a meal, it should be back down. I think it's too hard to do before a meal and 2 hours after, usually forget. So I say do before a meal. And if you do before dinner, it kind of tells you about lunch to dinner. If you do at bedtime, it tells you, between dinner and bedtime. So it kind of gives you that stretch. Depends on what your doctor wants to do. I have some people who are never given a meter. So I'll be honest, if you get diagnosed or if you have diabetes and you've never been given a meter, please ask for one because you would like to just kind of keep an eye on it.
Does apple cider vinegar help?
Well, that's a mixed bag. I don't know the latest, but what I did hear was some people say they take it, their blood sugars are down. I think statistically, there's been no correlation between apple cider vinegar and diabetes, but kudos to whoever has the courage to drink it. That's what I say, because that stuff is awful.
I had a question too. I was curious in regards to upcoming treatments for individuals who are insulin dependent.
Okay.
For your individuals whose bodies no longer produce insulin.
Oh, okay.
Or even for type 2s who are taking insulin. Are there any new medicines that are on the horizon that are very promising as far as treating diabetes or helping individuals manage their blood sugar and get a more optimal A1C?
Good question. I should have had a slide. So there are medications that are injectable that are not insulin. So if you kind of vaguely remember that slide where we had all those systems, we now have medications that can instruct your kidneys to pee out sugar if it's high, what the kidneys used to do. We have injectable medicines that work in the GI tract to slow it down so you don't get as big of a spike after you eat. So these are now for type 2, though I have pushed it and used it for type 1. They're used in Europe, but those are primarily type 2. For a person with type 1, and for type 2, there's a lot of technology. There is insulin pumps. We have a little device called the Vigo that you fill with insulin. You change it every 24 hours and you can press a button and give yourself insulin. We have all kinds of continuous glucose monitors, the little disc on the back of your arm that's the size of a quarter, or the Dexcom. I think both of those are on TV now. Those are continuous glucose monitors, and that we use, and it's actually looking at the sugar in your interstitial fluid. It's not the blood, but it's always monitoring and always giving that data. So there's new technology on checking your blood sugar. There's new technology, pumps, Vigos, for delivering your insulin. There are all kinds of new insulins coming out. One was just released 2 weeks ago that's supposed to be faster. So there's lots of different insulins, and not all injectables are insulin. Like I said, we have some really good ones that we'll use for either, unfortunately, they're good for prediabetes, but the insurance won't cover them. But we'll use them early in type 2 so that we can delay the onset of insulin. Not that insulin's bad, but these medicines that I've listed don't push blood sugars down. They just help your body work better. So it's always better to be safer. That, because I know you know what some of them are. Okay, we're trying to do our social distancing.
I know, it's good. Because I just can't see that. That was not a question. Are there any other questions? If you want to unmute yourself to ask a question, I'll give you, well, we could probably take one more question if someone has it.
How good is metformin for before you have to start taking insulin?
Metformin has been around since 1940. You will see it used a lot in prediabetes. Metformin actually, so the liver is the keeper of stored sugar and the pancreas creates insulin. So remember, it's that supply and demand. So the liver is supposed to put sugar in the system only in between meals and at night and when you need it. When you have diabetes, it loses its fine tuning button. So it just starts dumping sugar. You don't need all that sugar. So metformin actually tells the liver to back off and go down to idle or first gear. So it's used a lot in prediabetes. It's used a lot in PCOS. It's used, and a lot of, I have people who've been on it for years, and when they stop it, they realize their blood sugars go up a little bit. So it's been around for years. I know there's a lot of bad press out there about metformin. I get all kinds of things that people get off the internet. We still use it. It's a mainstay medication, and it's used usually early on, like one of the first ones if you're not already on it before you get diagnosed.
Thank you.
Sure. And also the new thing I just read, metformin helps with dementia. Now I'm thinking I'm looking forward to that myself. Okay.
I hope you guys enjoyed today's presentation. I thought Carol was just full of some really fascinating things, and especially the stuff on immunity and COVID I thought was really timely. So I hope that we see each other again soon. And Thursday, just keep an eye out if you would like to stop by our binder pickup and our drive-through for your goodie bag. We'd love to see you from noon to 2 outside in front of the Michigan Athletic Club.